Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor of the series here at Elsevier, and for our 8th podcast, we will focus on the August 2023 issue on vascular surgery. In this issue of 14 articles, the authors review the current state of common vascular pathologies, treatments, and interventions across a variety of arterial beds. Here to discuss 4 articles from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editors of the vascular surgery issue, Dr. Ravi Veeraswamy, the Elliot Robeson Endowed Professor of Surgery and Chief of Vascular Surgery at the Medical University of South Carolina in Charleston, and Dr. Don Coleman, Professor of Surgery and Division Chief of Vascular and Endovascular Surgery at Duke University Medical Center in Durham, North Carolina. Welcome to all of you, and over to you, Dr. Martin.
John, thanks very much for the introduction as always. And Ravi and Don, thank you so much for joining us, and to you and your colleagues for putting together a really fantastic issue on vascular surgery. It's going to be a tremendous help to any number of people at all levels of training. We have picked 4 articles as we usually do, and we're going to start off with infrarenal abdominal aortic aneurysms. And Ravi, I've got a few questions for you. I mean, the interesting thing is, for people of my vintage, it started out with open was the only way to do this, and then it was open's the way you do it, except in special centers where they can maybe do some endovascular. Now it's endovascular, except in special centers where they can do open. So we've gone 180 degrees, but in starting off, I mean, this is a topic that's gone a long, long way, but walk us through the beginning part of who do we screen? How do we know it works? And what do we do in people who've got positive screening studies? Let's start from there.
Thanks so much for hosting this session. I hope it'll be informative for the entire audience, and particularly for those who are not dealing with the nuances of this on a day-to-day basis. If we start with your first question of who do we screen, the data are fairly clear that screening works. One of the reasons that screening works is that aneurysms are often known as, quote, the silent killers. In fact, if you go back to, say, our parents' generations, a lot of people who, quote, died in their sleep, it was always attributed to they had a heart attack. So we actually don't know what the exact prevalence of aneurysms was or even is currently, nor do we know exactly what the mortality rate from ruptured aneurysms is precisely. Those patients don't get autopsies, obviously. So screening is important. In the article, it's mentioned that it seems like a distant memory, but a bipartisan bill in 2007, yes, both parties worked together a long time ago, and they looked at the data and agreed, took men who were smokers in their lifetime in America. There was an advantage to screening them with an abdominal ultrasound. This was known as the SAVE Act, SAAVE. And so when a person enters Medicare, they are eligible to have a screening ultrasound based on those criteria. And then it was ultimately expanded, and screening for anyone who has a smoking history is incredibly important. Women and aneurysms remains a controversial issue. Most of the studies that were done to establish prevalence, size criteria for rupture, survival had an overwhelming number and a paucity of women in those studies. The initial past just didn't have enough women to make a comment on whether they should be included in screening, and that is now changing very rapidly. And so as more attention is appropriately placed on understanding vascular disease in women, those screening paradigms apply to both genders. Once a patient is screened, I think, again, the data are fairly clear that below 4 centimeters, you can follow up looking at those patients every several years, I believe 3 years or so. But once you get above that number, you're starting to go to an annual screen or more frequently than that, depending on the rate of growth. The established or accepted rate of growth is somewhere in the range of approximately 0.5 centimeter or so every 6 months. If it exceeds that, then you need to really start following those patients more closely. In my practice, once patients get somewhere near the 5 centimeter mark, we start following them very, very closely as they're kind of in that territory where you're considering repair. And one final note, the beauty of abdominal aneurysm screening is that it can be done with an ultrasound, which is non-invasive, doesn't require radiation or IV contrast. And so it becomes a disease process that lends itself to a screening protocol pretty readily.
Let's say we get people going through the screening process and it's effective and actually people are showing up, which is all great. So then we get into with the somewhat moving target historically, but I think it's starting to stabilize at what size criteria are you thinking about repairs? 5 plus, any repairs under 5? How do you make your decisions from there?
It's a great question. So for open surgical repair, the data are very clear that 5.5 centimeters is sort of the quote cut point at which the perioperative risk, the risk of rupture is greater than the perioperative risk. So that's the number for open surgical repair. The exact size criteria for endovascular repair remains a little bit nebulous. The studies that were done, even in randomization, did not ever really use 5 centimeters as a cutoff. So there's some play there in that area between 5 and 5.5. I think there's a little bit of practice variation. Certainly anything smaller than 5, most people would not repair unless there was rapid growth or some other extenuating circumstances. Those numbers that I'm giving you are, again, for men whose native aortas are slightly larger than women. And so I think consideration has to be given to what the size, the maximal aneurysm diameter size is relative to the normal aorta. So if you have a smaller person and so on, then again, that's why there's a little bit of play in those numbers.
And I presume we're also factoring in these are people that we believe are asymptomatic.
That's correct. This is all for symptomatic patients. Of course, it's a very different set of criteria, and that's a surgical urgency or emergency.
Now, in my line of work, which is pancreatic biliary world, there's a lot of things where people have size criteria for bile ducts and pancreatic ducts and stuff. But if you really start getting into it, it's been the evolution of high quality imaging, which has led us more to look at configuration of issues rather than just size, which used to be simpler to get. So, one of the questions I sort of written down here as I'm going through this is, and this is a way open-ended question that we could spend 6 or 7 weeks on, but the evolution of EVAR. So lead us through how changes in imaging, and not just size, but geometry, for lack of a better word, influences your thinking on how have we progressed to make EVAR more likely now that we have a number of different devices available.
So that's a great question. So here's what I would say. First of all, let's take the size criteria itself. To date, maximal aneurysm diameter remains the single best predictor of rupture. There is a tremendous amount of work going on to try to do things like segmentation of the aorta, measuring stress, doing computational fluid dynamics, looking at biomarkers, and so to feel it's very ripe for current research. But in terms of what has been validated, it still remains the size criteria that we've discussed, which is interesting. Better imaging has led to a couple of things. First of all, as we get fine cut CT scans and patients are getting scanned for drive by an emergency room these days, you're going to get a full body CT scan as you pass the entrance. And so the rates of detection of aneurysms has simply gone up. We're finding more of them just due to the fact that people are getting imaged. And the CT scans are so sophisticated that you're getting 3 millimeter cuts. So the measurement of the diameter is more precise. With other more sophisticated technologies like centerline measurements, the what we call the orthogonal measurement or the precise diameter is better than it's ever been. And finally, the suitability of endostents for a given anatomy now can be determined very, very quickly because we have CT scans. We can measure the length of the neck distal to the lowest renal artery. What is the angle? What is the diameter? And those things are far easier than they were, even a decade ago, to be honest.
That brings me into the next thing. I mean, for those of us who grew up in the open era, one of the big changes was moving into the endovascular era was how we classify leaks and what do we do about them? Because as I understand it, and I hope you're going to maybe improve my understanding, we now have a series of endo leaks that mean different things. And so can you work us through endo leak classifications and what do we do for them?
It's a very unfortunate vernacular endo leak, because it tends to really stress out the patients when they get their written report. They all, of course, assume they're leaking blood, and so it takes generally half the clinic visit to reassure them that that's not the case. So endo leaks come in multiple varieties. The ones that this audience will need to be most familiar with are 1A endoleaks, which simply means that you have no seal of the endostent at its proximal most aspect. The way I explain that to patients is that's like having an unfixed aneurysm. You have a fully pressurized sac and there's no wall apposition of the stent graft to the aorta. A 1B is a similar situation, but distally at the level of the iliacs. Again, you have the endostent is sort of floating, is not up against the walls of the iliac artery, and so you have a fully pressurized sac. I'm going to skip type 2. We're going to come back to that because that's a whole hour podcast unto itself. Type 3 endoleaks are ones where there is blood going between the components. So a typical aortic endostent will be 3 pieces. And for some reason, there's blood that's getting between the pieces. Also, you can think of it as an unfixed aneurysm largely. When we get past type 3, that's getting a little esoteric, and you don't generally need to worry about that in the general surgery world. Let's go back to type 2s. This is the bugaboo of aortic endostents. So type 2 endoleaks occur because the endostent is in good position, it's functioning perfectly, all is well in the world, but blood finds a way to get places, which can be a little bit beguiling. So essentially what's happening is there are tiny lumbar arteries, iliolumbar arteries, sacral arteries that in a non-aneurysmal aorta go from the aorta out to the muscles of the back and the IMA and so on. When you put the stent in, there's reversal of flow. And so since the vascular highway is completely connected, flow reverses and it comes backwards, retrograde, through the IMA or lumbar vessels back into the aorta around the stent graft and can be visualized on a CAT scan. That occurs in roughly ballpark at about 15% of patients who get an aortic endostent. What the exact lethality and morbidity and mortality associated with those endoleaks, again, is something that's still being determined, but most of us feel very comfortable based on the data that most type 2 endoleaks can be observed. It's a low flow, low pressure system. You see it in the CAT scan, but a small percentage of type 2 endoleaks, roughly 5%, will have continued growth of the aneurysm sac. The one other thing I should mention is oftentimes we are getting full circle back to your question, a little bit at the mercy of the imaging modalities. If you have an aneurysm that's truly growing rapidly and it looks like a type 2 endoleak, you should be pretty careful that it's not what we call an occult type 1 or type 3. If it's really growing fast, that can occur with type 2s, but it's unusual.
And I should mention, and I failed to mention at the beginning of the discussion, the article that's written by Doctors DeFreitas, D'Ambrosio, and Fatima gives a really excellent description and series of classifications for anybody who's listening to the podcast who wants to go and see this stuff spelled out with great diagrams. I wholeheartedly recommend it to them. And before we leave AAAs, and this has been altitudinal, I'll grant you, but let's talk about what's the role for open repairs nowadays. And these are really in the hands of people who've got a lot of experience compared to the old days.
Yeah, your timing is impeccable because I did one today and took out an endostent. So it still does happen. So there are a couple of scenarios where we're doing open repairs. First of all, I do think it's important to try to present both options to patients in as objective a manner as possible. And I certainly try to do that. Maybe I have an unconscious bias when I'm presenting it, but I think patients deserve to understand, what their options are. For younger, healthier patients who can withstand a laparotomy and clamping of their aorta, certainly of the infrarenal aorta, I think it's an excellent option. Generally speaking, they will do very well. They'll have a hospitalization that's in the range of ballpark a week to maybe 10 days, what I tell them. And there's obviously some recovery period, but if they're, are fairly vital and they have an active lifestyle and are non-smokers and their physiology is good, it's a very good option. The problem is that most of my patients don't fit that category. They tend to be older, they tend to be frail, they have other medical comorbidities. And so I think open surgery has a role for sure, depending on the specific patient. The other place where open surgery is used is to explant endograft that had failed. That was the case with my patient today. He had a type 2 endoleak. There was unremitting aneurysm growth, and he was overall vigorous enough to undergo explantation. And of course, the obvious question is, well, maybe you should just have done him open in the first place. And that's, that's something that's a little bit hard with a retrospectoscope to go back and look at. But there's definitely a role for open surgery for patients who have failed endovascular treatment, who are vigorous enough to, or healthy enough to get open surgical repair as their index operation. And then there are other sort of less common scenarios, inflammatory aneurysms, patients who have primary aortic infections, and then, of course, patients with connective tissue disorders who should absolutely get an open surgical repair.
Well, as they say, there's nothing to increase cardiac afterload like an aortic cross clamp. You do have to make sure that the pump's up to that kind of work in folks. But no, thanks very much. And actually, that kind of segues in talking about particularly the infra-abdominal stuff to the next topic I'd like to go over with Dr. Coleman, Don. So, Don, the mesenteric ischemia article by Scallon and Duncan. I mean, this is near and dear to my viscera. I spend a lot of my life at the inferior border of the pancreas, and certainly a lot of the vessels are there. But, I notice it in terms of pathophysiology, they kind of focus in their article more on thrombosis, embolism, non-obstructive mesenteric ischemia, kind of not so much on outflow issues like mesenteric vascular thrombosis, but just bring us through your sort of general approach. The person comes in with, pain out of proportion to exam. You're either getting a call from ER docs or PAs or general surgeons or somebody who can't tell you what the pulses were in their lower extremities half the time, I'll bet. So what is your thought when somebody calls up and tells you that they think somebody has ischemic gut?
Thanks for the question, and thanks for the opportunity to be part of the podcast today. We're really excited, Dr. Veeraswamy and I both, about this supplement. And I love the manuscripts that you chose to highlight today. And I'd say that themes that were really showcased by Dr. Scallon and Dr. Duncan are at the heart of what we would be called for as vascular surgeons. And perhaps some of the more downstream challenges can accompany other surgical emergencies, but may not require revascularization strategies, with one exception maybe being non-occlusive mesenteric ischemia, which we just see so infrequently in our really critically ill and challenged patients. But I think that for the most part, if a vascular surgeon's getting called because there's a concern for mesenteric ischemia, our algorithm prioritizes thoughts around in situ thrombotic or embolic disease, and thinking urgently towards medically optimizing, stabilizing, and quickly revascularizing patients to optimize their outcome. And the approaches for those strategies may be very different, dependent on what the etiology is. And so there are some nuances to think about if this is in situ thrombus or acute on chronic mesenteric ischemia, or if it's related to an acute or sudden cessation of flow that you might see in an embolic disease state. The venous occlusive disease processes, NOMI, for example, these are so rare and so much less common. And frankly, I think their course looks a little bit different as well. And so if you really do have a true case of arterial ischemia that's sudden onset, especially for somebody who's got an embolic process and they lack any type of collateral hypertrophy or precondition, it's a super non-forgiving diagnosis because the clock starts as soon as the clot forms, and these diagnoses are often very delayed. And so there are few true emergencies that don't give you at least a few hours of buffer. And I think this is one of those in vascular surgery.
One of the things they emphasize, in my opinion, if you're going to take somebody to laparotomy that you think has an embolic or a thrombotic event of their SMA particularly, you should be prepared when you get there to deal with the vascular problem. And there are some people that go take them and perform a laparotomy, see if there's dead gut, and then close them and ship them somewhere else. The phrase you used was it has to be done quickly, which I agree with. But I think if this is a real concern based on initial assessment, they need to be someplace where once they get opened up, people can go the distance. But what are your thoughts on that?
Well, I don't think I could agree more. And I think we're saying the same thing, because doing something quickly necessitates medically optimizing, controlling contamination, but also revascularizing. And it's clear in other, this crosses lots of other vascular phenomenons that are time sensitive when we think about who can do what and who should do what, and where there may be precedents within a hospital institution or resources that are limited outside of large academic centers. But I don't know that acute mesenteric ischemia should be viewed differently, perhaps, than vascular trauma. Essentially, what the patient needs is the right operation from whomever can give it to them, but it is time sensitive. And so there is an element of stabilization and maybe damage control responses that can be considered. But ultimately, the patient has to find themselves in a clinical care environment in which a revascularization procedure, and ideally something with a balanced approach towards endo and open resources, are available to them. Again, because I think there are nuances to think about when somebody presents, whether or not it's acute on chronic disease with in situ thrombus or an embolic.
Yeah, I mean, in most of the places I've worked, the larger places throughout the majority of my career, usually staff vascular surgeon and myself, plus or minus our teams, we would descend on these people at the same time, all hands on deck for this kind of problem, make sure we could get where we needed to go. What, if any, do you think is the role of laparoscopy in assessing gut viability before deciding how to approach the arterial problem, if you're going to consider catheter-directed therapy or something else? Or is there a role for catheter-directed therapy in this?
Yeah, so there is a role, and we're seeing that, and I think the authors hint at it, that I don't think it's become the standard. And I do think that there, again, are some nuanced considerations where maybe laparoscopy and certainly endovascular or less invasive diagnostic and therapies can be considered. I think for somebody who has embolic disease, that's probably not the case because, again, these patients lack preconditioning and collaterals, and the clock has started as soon as that embolus lodges. And those are cases where I think if you've got, if you're considering the diagnosis, it is so time sensitive, those patients just need to go for a procedure. And we do know that there's a role for endovascular therapies in acute mesenteric ischemia, but what it does offer potentially is a delayed reperfusion and an inability to assess the bowel. And so that may be where, in the right context, a coupled collaborative approach with a diagnostic laparoscopy and a catheter-based procedure can be helpful. And certainly in cases where I've seen it most commonly used are in some of our higher risk patients with hostile abdomens, where it may take a significant amount of time to even gain exposure to a vessel. If somebody is coming back with a thrombosed stent or something that has failed and you're trying to salvage or offer secondary patency, that can be very helpful. And frankly, our endovascular armamentarium continues to expand, and we have some really kind of refined and advanced technology now that allows us to offer a more aggressive thrombectomy in a way that can depulk some of this clot burden pretty effectively. I'll be honest, it's not necessarily my first line as a vascular surgeon in practice, but it is first line for many. And I think the data would suggest there's absolutely a role for this in the care for patients.
Anticoagulation with heparin for everybody as soon as you think about it, or?
100%. We love heparin, and I don't think vascular surgeons are afraid of bleeding. So it's one of those medications that I always worry is going to get stopped during transfer or held when the patient gets to pre-op. And we're not afraid to make incisions, right, when patients are therapeutically anticoagulated. And the lack of heparin risks clot propagation, which can really complicate outcomes.
On the other end of the spectrum a little bit, the chronic mesenteric ischemia side. I mean, I personally find it fascinating. I get sent a lot of people with abdominal pain that nobody seems to, and not from you guys, not from vascular surgeons, obviously, they always think about it. But there's a lot of other people that don't think about it, who see people with belly pain, and everybody's got, it's always their gallbladder or their pancreas until we find out whatever it really is. But, there are a lot of options for repairs and either endarterectomy, endoluminal therapy, certainly retrograde, antegrade bypasses. You want to walk us through your thinking on this challenging set of folks?
I mean, we're all so shaped by our lived experiences and patient experiences. And so I don't think it's surprising that, again, much like acute mesenteric ischemia, chronic mesenteric ischemia can be a pretty delayed diagnosis as well. But in contrast to the former, it probably should be delayed because we have to exclude other things first, right? These are often really older, now frail or debilitated patients that have lost weight, that usually have some other comorbid risk factors about them. And so ensuring that you've been really diligent with your differential diagnosis and things like peptic ulcer disease, or even more importantly, malignancies have been excluded. So these patients really have to have gone through a fairly rigorous GI workup. They need to have been scoped. They need to have been considered for other things that might drive their symptoms. And so we often are engaged kind of late in the game. And I think in general, that's probably okay, because you do want to have a workup that's complete. You don't want to miss something. And we all get a little tunnel vision when we're operating within our own scope of practice. In contrast to acute mesenteric ischemia, I do think this is where the data has overwhelmingly suggested that endovascular therapies have become the standard of care. It's not dissimilar to thinking about renal artery work for occlusive disease, but covered stenting, now even from kind of standard femoral access with the steerable sheaths we have available in the lower profile, covered stent grafts and uncovered stents that we get to utilize, have facilitated a much less invasive and less morbid revascularization option for some of our sickest patients. And when you think about the kind of phenotype of somebody coming with chronic mesenteric ischemia, they generally aren't well. And so they don't have the same physiologic reserve that you would necessarily want to see. And I think they're a little different than most of our conventional aortic aneurysms that lack concurrent occlusive disease. And then they're horribly debilitated, right, and deconditioned and malnourished. And so they have this real setup to do poorly with surgery. An interesting phenotype that I just want to qualify is our obese patients. And there's a lot of recent data that kind of qualifies the fact that this delay in diagnosis may be even more pronounced now, acknowledging that we have such an epidemic of obesity in the patient population. You can be morbidly obese. You can lose 50 to 100 pounds. You can be malnourished, by definition, and yet still be overweight. And nobody wants to consider the diagnosis in those patients, and their outcomes are significantly worsened. And I don't know that we necessarily touch on that in the chapter, but I think it's important as we think about just some of the population health threats we have as a society across the U.S.
Yeah, and that demographic is rapidly going in a direction that's unfavorable. Hopefully we'll make some ground on that. Just to shift gears a little bit and maybe get back to Robbie here, maybe we'll skip a body cavity or at least 2/3 of one and work our way up to the aortic arch, our way to the carotids. The article on carotid artery, various issues of carotid artery by Banks and Pierce. This is another one. I mean, there's probably nothing in general surgery training and vascular that you don't get asked more questions about than all of the studies that tell us why we do what we do with carotid artery stuff. And carotid artery as discipline, as a surgical science, to me is one of the great achievements of actually understanding why we do what we do. It's sort of right up there with gastric physiology for those of us who are biased towards the foregut. But certainly carotid artery problems provide us with probably the most devastating downstream effects you can have, CNS failure or death. So let's start out with just your thoughts again. Let's go back a little bit like with the AAAs. Who do we screen? Why do we screen them? What are we going to do about it?
I classify this as a public health problem. And the number of patients involved, this is not an esoteric little niche problem. And we're talking about hundreds of thousands of people a year across the country that are affected by stroke, CDAs, and the true morbidity of this is difficult to capture quantitatively. What happens to a patient when they have a stroke is devastating. And that's without incorporating what happens to their family, their loved. Your life changes in an instant. So it is a critical disease that we have made tremendous progress in managing and treating, but where there's still a lot of unknowns, a shocking level of unknowns, believe it or not. So let's start with screening. Almost every attempt at widespread population-based screening has been shown to be largely ineffective. So going to the shopping mall and so on, just screening everybody who comes by. That's what I mean by population-based screening. However, people with risk factors should be screened. So hypertension, diabetes, peripheral arterial disease, consideration for coronary, people with coronary artery disease and so on. So in those patients who are at risk for carotid artery disease, and at that point, it's a little bit of a vernacular, right? That's not really screening. Screening, these are people who are at risk for it. So I think we should be careful about which word we use exactly. We are looking at patients at risk already due to their comorbidities and their lifestyle and so on. I guess I got the two easy ones as far as screening is concerned, because carotid screening can also be done by ultrasound. It is painless, non-invasive, no radiation, no contrast, and the criteria, although several exist, which we can talk about in a second, it's fairly clear who needs to be followed more closely, who needs an intervention once you have that initial carotid ultrasound completed. Let me make a quick comment. There are multiple systems or multiple algorithms or standards for what constitutes stenosis in the carotid system. Very recently, thankfully, there has been a very, very good attempt to pull those together, pull the community together, and have a unified system. So iCable, which is the sort of governing or accreditation body, has put out a set of standards for what velocities constitute which degree of stenosis for carotid arteries. And I would encourage all the listeners of this podcast to talk to their vascular lab or talk to their hospitals and make sure that they are following the iCable guidelines for how the test should be done and the iCable sort of criteria for how the reports are read out. I think it's really important so we can bring the whole field together across the country and the world. So screening is important for patients who are at risk. And what do you do when you get someone who falls into a degree of stenosis that's greater than 50%? Well, let's take the easy one first. For symptomatic patients, that's actually fairly straightforward. You have, more than 50% stenosis, and you're having TIAs, or certainly if you've had a CVA, I think there's very little controversy in that group. They benefit from an intervention. Managing those patients with dual antiplatelet therapy, and the only place where there is some controversy is exactly how soon do you intervene upon them. And then what's the modality of intervention, being stent versus endarterectomy. But at least we all feel fairly certain that greater than 50% stenosis with symptoms warrants intervention. I think it's a little bit trickier in the asymptomatic group of patients. And this is where there's been a lot of movement over the last several years. It's a little bit of lots of heat, not so much light, unfortunately. And so you have one group of physicians who thinks that maybe medical therapy alone is sufficient, and that no one who's asymptomatic should get an intervention. You have another group of physicians who sort of feels that, well, if it's above 80% or so, as it's a number that everyone has coalesced around, that greater than 80% stenosis if you're asymptomatic warrants intervention. And then, of course, if you were to take a multiple choice test, the textbook answer would still be 60% based on the ACAS trial, right? So it's a field that's very fluid right now. And that level of confusion has been compounded by the fact that some people are using ultrasounds, other people are using CT scans. The original studies were done using angiography. So at a risk of confusing your readers further, I would say the symptomatic patients are straightforward. The asymptomatic patients in the vascular surgery community, most of us have, again, coalesced around 80% or higher, warranting serious consideration for intervention.
But one of the things that intrigues me in general in our entire discipline, not just vascular, but people have a hard time looking at things through the prism of the time. And so this is, I think, a good example. Like, what is optimal medical therapy? Because a lot of these studies were done when a batch of drugs weren't available. And it seems like a lot of, and at least my recollection when I went through it, and granted, it's been a while since I've done this kind of work, but operations outperformed optimal medical therapy pretty much all along in the ACAS trial and NASCET and other things like that. But now you get along to people saying, well, now we've got different antihypertensive, we've got statins, we've got different lipid managing agents. I'm not convinced that, given the fact that plaques form in an irregular way and do irregular things with less predictability, that you just can come up with a model that says, for everybody whether medicine's better than doing something that reshapes the lining of a vessel, even though there's some complications that go along with that. So where do you think we are now for optimal medical therapy between plaque modifying agents and platelet modifying agents?
Optimal medical therapy has clearly improved since those landmark trials were completed, but so has surgical therapy. And the perioperative stroke rate is much lower today than it was in 1980. The question that I have, or the way I think about this a little bit, is that we've shifted the entire therapeutic window a little bit for both arms of it, right? And My guess, the window shifted for both arms, so you ended up in relatively the same place that you were potentially. Platelet modifying agents have clearly had a huge impact, specifically, obviously, Plavix and dual antiplatelet therapy with Plavix and a baby aspirin is sort of the standard of care now. After a person has had a cerebral event, that data is fairly clear that they are of benefit. Whether they have long-term benefit in patients who are asymptomatic, however, I think remains a little bit murky. Overall, these agents are relatively well tolerated by most patients. And if possible, I think they offer benefit to at-risk groups, your diabetics, your hypertensives, your peripheral arterial disease patients, your atherosclerotic patients, and so on. I don't think it's clear that they help patients who don't have risk factors, who are asymptomatic.
Once you get to the decision to intervene, and one of the questions that generates a lot of anxiety when you're giving people the boards is when you ask them to sort of explain their thinking about monitoring versus shunting versus doing asleep patients versus doing awake patients. So can you walk us through your thinking on, you've decided whatever your criteria are, that it's time to go do something to change the vascular structure leading up to somebody's head?
The most important thing is, like almost anything in surgery, you need to know what you're good at doing and do it that way. And that's not a cop-out answer. It just means that you have to have a system and you have to be comfortable and facile and really good at doing it your way. And if your way is doing it with EEG monitoring, which I've never used once in my life, great. Do it that way, right? But you have to have your system, your criteria, and you have to look at your personal outcomes and make sure that they're meeting national benchmarks. So that's the most important thing. I think for me personally, I tend to be a selective shunter, and that selectivity is based preoperatively on a couple of factors. The most important being, what is the contralateral carotid degree of stenosis? So, for example, oftentimes I'll have to operate on someone who's completely occluded on one side, and now I'm operating on the contralateral side. Yeah, you're going to shunt that patient. Intraoperative monitoring, there are, again, a plethora of ways that you can do it. Find what works at your institution, I would say, is the real answer. For us, it's cerebral oximetry, or we try to do a lot of our patients awake with local and regional anesthesia. And between those two modalities, that's worked very well for us. But it would not be appropriate for me to say this is the best way to do it, because that data doesn't exist. And the best way is the best way you can do it.
Oh, that's great. Thoughts on transarterial work?
The first thing I'll say is this is a little bit of a black mark for the medical community. If you go back in time about 10, 15 years, you had people who were proponents of transarterial work and those who were very, very against it. And I think everyone brought way too much emotion into it. And it was really not particularly well done by anybody. There was actually a great paper. If you looked in the cardiology journal circa 2008 and did a meta-analysis, they would all tell you transfemoral arterial stenting was better. And if you looked at the open surgical journals, they would all tell you that endarterectomy was better. And that's not the way that's not doing the best for our patients, right? So my thoughts on it are, be good at all of them. So you have a versatile toolkit available to you, and you can apply it selectively for each individual patient. So what does that mean? Well, you should be good at doing transcarotid arterial revascularization, TCAR, which consists of a small incision at the base of the neck and a venous access in the groin, giving you a flow reversal mechanism. You should be skilled at carotid endarterectomy with patch angioplasty, and you actually should know how to do, or have someone who at your institution or someone who's a friend who knows how to do transfemoral stenting, because those cases still have a bit of a role. Beyond that, I think that the current data would tell you, from what we can gather, that TCAR and carotid endarterectomy are very similar in their risk profile. Obviously, TCAR has not been in existence for decades and decades like endarterectomy has, so we just can't answer the question of, is it going to last 30 years? I mean, no one knows the answer to that right now. So I think between TCAR and endarterectomy, you can cover most cases, and if you are performing carotid surgery, you should be facile and familiar with both of those. Transfemoral carotid artery stenting might be something that I wouldn't undertake unless you are doing it frequently. There are tips and tricks and skills to it, and you might want to make sure that goes to someone who does it with some frequency.
No, that's great stuff. It actually leads us a little bit into the final chapter we're going to talk about on vascular injuries from penetrating trauma. In my other life is doing a lot of surgery in war theaters and running forward surgical teams and combat support hospitals and stuff. This is where general surgeons do a lot. It's almost all open. As a matter of fact, it is all open. At least it was when I was there for the 16 years that I was doing it. But so, Don, I'd like to talk a little bit. I mean, certainly penetrating trauma and blunt trauma are two completely different animals when it comes to traumatic vascular injuries. And this article by Stafford and Singh focused largely on penetrating injuries. I would say in my experience, at least military stuff, you get a fair bit of neck work. You get a lot of lower extremity work. You get some upper extremity work. And you get very little thoracic or abdominal stuff just because of body armor patterns. So unless you're taking care of civilians, you don't see as much in the middle. But let's start with the neck, just because this is another board's favorite of zone 1, 2, and 3 injuries to the neck. And, help us walk through your approach to the person who comes in with one or more entry wounds somewhere between the top of the clavicle and the bottom of the occiput.
Yeah, thanks, Ron. I appreciate very much the context with which you've introduced this final manuscript. And at some point, we'll have to talk offline about your service, because I'll qualify that I have a similar perspective, having spent 3 deployments overseas with the Army. And Dr. Singh, similarly, is a surgeon soldier who has served overseas as well. And so I think that what you've just highlighted so beautifully is captured with some of the introductory comments for this chapter, which I think are really important, really essentially acknowledging that so many of our civilian trauma treatment advances have originated in the military context of past conflicts. And your lived experience thinking about kind of post 9/11 Middle Eastern conflict has looked different, perhaps even than the war patterns we saw before that from prior conflicts. And who knows what yet is to come next for all of us. But I think the neck trauma is a really interesting one to think about. And I do think it's one that begets a fair amount of anxiety to general trauma and vascular surgeons alike, because it's actually not that common if you look at civilian trauma patterns, but can be not just life-threatening, but importantly, quality of life-threatening when you think about the stroke risk incumbent to carotid injuries. And this is where you reference the kind of trauma surgeon's comfort with open surgery and I think damage control and mitigation of immediate hemorrhage, immediate contamination, other things that are immediately life and limb threatening. Sometimes that gets a little trickier when you're thinking about the zone injuries in the neck. And we learn as medical students, zone 1, zone 2, zone 3, the hard and soft signs of hemorrhage and who goes for an exploration. I think what the endovascular landscape has shown us and some of the more contemporary civilian trauma data is that we can probably be a little more conservative and take the liberty of working through a careful diagnostic set of considerations to even zone 2 traumas that feels uncomfortable, I think, for the people that trained me and probably you as well, Ron. But also there's a very meaningful role for endovascular therapies when you think about really proximal and distal trauma. And so I think how I respond to those traumas when they come in, and I've newly transitioned from an academic center in the Midwest to an academic center in the South. And the phenotype of the trauma patient that we're seeing here is different, and there's more of it where I'm at. And so my civilian lens has shifted in the last 12 months. I think dependent on when we get engaged, that has significant implications on how a patient is managed. And again, it gets to resources and how collaborative the teams are. And I do think that collaboration is essential in this space because ideally you're going to find this patient potentially in a hybrid operating room, or at least in an operating room location in which you have some advanced endovascular or C-arm hybrid capabilities. Because not only can endovascular means offer you transient hemorrhage control, proximal balloon occlusion. And sometimes that's what you need to kind of facilitate a definitive treatment. It also can offer therapeutic treatment that can stabilize a patient who's acutely at risk for cerebral ischemia or hemorrhage. And the role for covered stenting across some of these injuries cannot be underemphasized. And then embolization for certain things that it's appropriate for. And so I think just considering neck trauma broadly, if I have the opportunity to see a patient before they end up in the operating room, I think it shifts based on their stability and neurologic status, what type of meaningful workup we're able to accomplish before they end up in an OR. And then ideally routing them to an endovascular room where you can obtain vascular access for diagnostic purposes, hemorrhage control, and maybe even definitive treatment.
Yeah, I think, and I wasn't aware of your military background, so thank you for your service. I appreciate it. We should talk about that sometime offline. One of the things that, at least in the military sector, you try to get everybody trained up on, especially when they're new, is how to get shunts in quickly. Not to make everything perfect on the first round, as you well know. And where I found that to be probably more common was in the neck and in the axilla. So thoughts on, you've got some gaping wound from something and there's an artery gone sideways in the inside. And it's not just, I've got a stab wound and they're acting funny or their tongue's pointing the wrong direction. So what are your thoughts on that sort of thing?
Yeah, so I love shunts. I think they're underutilized across the board, except in the military. And they're utilized appropriately in the military because we follow this escalation through roles of care, right? And at no point in role 1 or 2 should you be doing definitive vascular management. Shunting is part of your clinical practice kind of guidance. And that's not the case in the civilian side. But what I think is the case is we don't necessarily have adequate vascular surgical coverage across big swaths of territory in the United States, right? And so there has to be some education and basal comfort of vascular damage control that can be implemented someplace where there is need to stabilize a patient so they can be progressed through the echelons of care, make it to, a tertiary care center that can offer definitive vascular management. And that's where I see a lot of value in the use of shunts that may be right now under recognized. And I think also when you're thinking about multidisciplinary care of patients with polytrauma, and the neck is a really good example when there are other aerodigestive injuries that may have implications on how you manage your vascular wound. And we think about this in extremity when there's a comminuted bony fracture that requires some type of fixation or stabilization. And you really want that done before you do your vascular bypass because it has implications on extremity length and other things. I think there's a real meaningful role to put a shunt in and let other teams prioritize things that may or may not be more time sensitive, and specifically those things that may have an impact on how you manage your vascular injury, especially in contaminated fields.
Well, external fixators do make excellent self-holding retainers, kinds of vessel loops and everything else. And it's great to have the erector set out when you're trying to put vessel loops and sutures all over the place. And I love my orthopedic colleagues to pieces for getting the bones up to length first. And then, of course, with the neck, you kind of got to get the blood flow going back to the brain. So you do have to think about your priorities.
Yeah, that's right.
But let's think about the abdominal stuff, because certainly in the civilian sector, our average citizen isn't walking around body armor. At least we hope not. I guess we see a little more of that in the news. But in general, somebody's likely to absorb a round or get stabbed or have something sharp go through them at a construction site. And one of the things I found when I was examining for the boards was people were confusing which areas of bleeding needed to be explored under which circumstances and which didn't. So walk us through your thought on intra-abdominal zones and how to approach them.
Yeah, I think that's another really great question. And to be very fair, I think the challenge always that you might agree to is in the retroperitoneum and what that looks like. And I think the control and the considerations here have also changed dramatically. And this is where, again, I think being engaged early on allows us to get patients to a hybrid room, potentially where diagnostic catheter-based studies, aortic balloons potentially, can be exceedingly helpful. And so, I was trained in an era before Hybrid rooms were online well before at least off-the-shelf prime-time Reboa was available, when essentially everybody that was hemorrhaging would come in. They'd have all of their quadrants packed off. If they continued to bleed, they would have a supraceliac cross clamp on. And I don't think that necessarily is the case anymore. I will say that Reboa has changed the landscape, imperfect as it is for civilian trauma. I think it still has a place. And I think this is, again, another space where collaboration is really critical. Getting patients for hemorrhage control back to an operative setting where quadrants certainly can be packed, especially if there's ongoing hemorrhage that kind of prohibits safe imaging with a CT scan. That's the perfect patient to be, I think, in a hybrid room, because you have no imaging going in. You actually don't know what's bleeding. When you have retroperitoneal bleeding, ballooning on either side or centrally, it helps you understand what might be the culprit vessel, if that's going to be your kidney, your renal arteries, a venous structure, or the aorta. And all of those are going to be approached a little bit differently.
I found some parallels between our previous discussion about mesenteric ischemia and exploration, and then approach to mesenteric vessel injuries. And in the chapter, which is a wonderful chapter, I mean, like I said, I spent a giant chunk of my life lifting the pancreas off various structures and trying to not hurt other things. But their descriptions and their diagrams of how much space there are between the initial visceral branches, I wish there were that much space to work around.
Yeah.
To me, their zones are a lot more compressed. And, there's sort of the retropancreatic SMA and then everything that's coming off of it. And I think there may be a little more art than science to how you deal with those, particularly if there's a penetration there. And particularly if there's a concomitant venous injury, that can up the ante a little bit.
I don't disagree that the diagrams, any diagram, is always a little bit more generous, right, than what you feel when you're actually in somebody's habitus. But I think there are a few things that are relevant to consider, because the average habitus of an adult U.S. civilian generally involves some central adiposity, and I think that challenges some of the exposure you have. But in youthful patients, in really trim patients, in children, for example, that looks and feels very different. And you can actually get a lot of exposure through medial visceral rotations bilaterally of those branch vessels. The other thing that can't be understated is how those tissue planes and relationships are altered or obscured when there's been a lot of hemorrhage, and planes are, dilated. And frankly, what you should be seeing based on your textbook pictures, we know you don't see that, right? That anatomy is never so clear when there's been dramatic penetrating trauma and a lot of hematoma. And sometimes finding the bleed can be a challenge if there's been hemostasis in the interim, especially if it's a vein. And so I think loading the boat really matters, and it really helps. And there are some, pearls that I think matter, but a good medial visceral rotation, especially one in which you're prepared to cross clamp things when you release your tamponade, I think that gets you pretty reasonable exposure of most retroperitoneal structures, with just a few exceptions.
And I think Reboa has been super helpful for that. I mean, John Brash was one of my early mentors. So when you work with John Brash and you've got the job that's named after Cattell, you better learn how to at least mobilize the right side. Teaching those maneuvers to residents was something we did an awful lot in the early open in the days. And I don't mean to hark back on Life Was Grand When, but a lot of us learned how to operate doing open gallbladders and mobilize the right upper quadrant. And that's a almost gone art now. There certainly are other, when you do a lot of pancreatic biliary work, you'll do more of it. But our trainees and junior staff people are not as comfortable. All the GI viscera are midline structures. I mean, everything can come up and go over. I mean, that's the way it's built. But people don't get the same opportunities that they used to with that. And I think it's certainly in the military, we have the ASSEC courses and things like that, where we teach people this for very, very specific reasons. We don't have that as well duplicated, I think, in the civilian sector. I think over time we may, because to your earlier point, civilian surgery largely follows military advancements. Not in everything, but in a lot of things. And I think it'll go there. But maybe some quick thoughts on, obviously, penetrating abdominal trauma has a very high likelihood of being associated with gross contamination of the field. Give us your thoughts on when you're going to do in situ repairs and deal with the contamination and cover it versus extra anatomic is probably a terrible word. I know some vascular surgeons would slap me sideways for saying it, but to go to some extra cavitary bypass with exclusion, what are your thoughts for when you'd approach one by one route or the next?
For the abdomen, I think that's a really great question. And frankly, it also relates back to acute mesenteric ischemia when you're thinking about how to revascularize an SMA when there's been gross bowel kind of transmural necrosis and perforation. And I think that it's in part thinking about when you can leverage sometimes interesting and thoughtful and creative revascularization tactics and trying to keep things in situ without conduit, but then also just urging the scientific field forward when we think about novel conduit that is coming. And it's not dissimilar to thinking about a blast injury to the leg, whether or not that's, an explosive injury from an IED, or if it is, some type of mangled extremity that's coming in from some other reason. That's just dirty. And so we think about that a lot because ideally you're going to want inline revascularization, and often the native vasculature won't give that to you. And so you need to revascularize with some type of conduit. That may be where, if possible, covered stents can be super helpful if there's just a short defect, for example. I think this is where there is increasing interest in homograft that's been processed as an alternative to something conventionally prosthetic like PTFE or a woven conduit. And this is where really new technologies matter. I know that there's been kind of humacyte trials now in trauma literature and other things up and coming that are engineered for this specific kind of utility. And I think that matters a lot. But sometimes all you have is plastic. And sometimes that's what you need to do to stabilize, knowing that it may or may not fail. And that's where being really thoughtful about coverage, omental flaps, extended antibiotic use can be really helpful. But often you can get away with primary repairs or reimplantations that don't require conduit. And I think from an extra anatomic perspective, when I hear that, I just think of something that's extra cavitary that would be for an aortic injury, right? And that's thinking about AXFEMs or even thoracofemoral bypass for somebody who needs to have their aorta reconstructed. In the renal and intestinal space, I think this is getting creative and using your splenic and hepatic arteries as inflow to other branches. Those are super valuable revascularization techniques, but not very many people are comfortable with them, to your point earlier about some of the gaps in training we have right now. And our general surgeons struggle with both, I think, open training with the rise of laparoscopy and robotic surgery. They struggle, I think, in getting really impactful open experience in the vascular space because so much of what we do now is endovascular, and our vascular trainees feel the same limitations. And so we have a growing workforce in which some of these really important open surgical principles are maybe coached, but they don't have the same reps they once had. And I do think that matters. And I think it is prompting a lot of high-level discussions around maintenance of certification, kind of super fellowships, if you will, in certain spaces, thinking about regionalization of care. But we do have a workforce right now that is not comprehensively equipped to care for some of these high-level problems. And taking a multi-pronged approach to tackle that, including some of the concepts with forward and damage control elements that can be done before they get escalated, and also just thinking about how we can better refine our trainees to get the skill set they need, and leveraging other innovative educational tactics is so important.
No, you're right. But I mean, I remember the days when I was involved in a portocaval shunt a week, and hips came around, and I was there when Ernie Ring presented the original paper. I was never so happy to see something come up that would take a whole chunk of work that I was doing as a resident at that time out of my life. That was fascinating work. Sewing veins in that situation is another skill set that we've lost appropriately, but we just don't have it like we used to.
That's right. And they're so fragile. And so much of it is how you handle the tissue, right? I remember when those portal venous shunts fell off the board.
In the early days of my taking the boards and then being an examiner early in the game, you were guaranteed a question on some kind of portal venous shunt. And it usually wound up doing something mesoatrial or super clever. And then we didn't get to ask those anymore. They went away. But that's okay. Life changes and we move on. But but it is a skill set. Just maybe one last comment before we leave this topic, but the extremity work, especially with people getting much better about using tourniquets, what should we add into the mix that people should know about these extremity, especially reperfusion injuries and other issues that come up when we take down the tourniquets, assuming that we don't make the patient hypotensive in the process of doing it?
Yeah, I mean, I think with extremity work, there are a couple tenets that really matter. And I think, tourniquets high and tight, that's classic in the military setting. I don't actually know how common it is in the civilian setting to be implemented and executed as we would be accustomed to in the military. And again, it gets back to that forward damage control piece. And I think that a few things that I have observed, again, just with this recent transition to a much higher volume trauma setting in an academic climate in the South, is that communication with your anesthesia partners is absolutely critical when you're going to, bring not just a tourniquet down, but revascularize somebody who's been acutely ischemic for an extended period of time. Time to reperfusion matters. And so it's been really well described now in multiple civilian and military trauma pieces that the quicker you can restore perfusion, and not just thinking, well, by 6 hours, it is hourly up until 6 hours. And even thereafter, the sooner you can restore perfusion, the better functional recovery your patient's going to have. And so it really matters. And reperfusion can be accomplished again with a shunt. So shunt early if you can't definitively revascularize. And if you're going to do, for example, an autogenous bypass to a transected femoral artery, I don't think it's wrong to shunt while you're shucking vein, right? And then I think it's important to consider other injuries. And so it's always life over limb. So shunt a limb while you're, taking care of other injuries and polytrauma. That's okay. Having a fracture reduced before you reconstruct matters, because you're going to have length changes that happen that will impact the quality of your bypass and potentially the long-term durability. And then reperfusion injury is very real, especially in the young patient, again, that lacks preconditioning and preformed collaterals. And so thinking about fasciotomy early is important, although it's imperfect, especially in somebody whose neurologic exam is not reliable. And how you manage that fasciotomy in those wounds is a whole nother discussion, that we can table for right at the moment. And the final thing I'll say is that I do think that there's a trauma lens that one can look at these cases with and think about damage controlling things in the moment, revascularizing, limiting time of ischemia, thinking about contamination. But you also have to look at these reconstructions with a longer term focus, not just thinking about optimizing medical management with antiplatelet therapy after surgery, but how you're going to survey your reconstructions. And then what's your plan when this fails? Because these can fail. And generally, the trauma patient is a much younger, healthier, less comorbid patient than the patient who's coming in with chronic mesenteric ischemia or a big AAA or carotid disease that Dr. Veeraswamy has spent such time sharing with us today. And so the goals of care should always be patient focused and shared. You don't always have that liberty with trauma patients. And so giving them the best outcome early on really matters. And I think that's where vascular surgeons can add a ton of value.
Well, Dawn and Ravi, thank you so much for the time. We obviously could have spent several hours on any one or even a subset of these topics and never run out of things to talk about. It's fascinating work. I do somewhat miss the days when it was more blended with the world of general surgery, but I'm super psyched that there are excellent subspecialists like you to get better results than we used to when everybody was so at everything. But any final comments either of you'd like to share with our crowd before you go away, and tips for the general surgeons from vascular wizards such as yourself?
Appreciate the opportunity to participate in putting this together, because it forced me to get out of the very, very insular world that I was in and understand the challenges that my surgical colleagues have, right? And I think that's really important. I think that even though we have become more specialized, the camaraderie and the collaborative nature of surgeons ultimately leads to the best results for our patients. And I think we need to maintain that, even if the specific things that we do are different, that ability to communicate with other specialists and put all of us together to end up with a great outcome is really what makes us fun and benefits our patients. So I thank you very much for giving me the opportunity to participate in this.
Don, any final thoughts on this?
No, I would just echo everything that Dr. Veeraswamy said and amplify that one bit further to say it's such a team sport. We owe it to our patients and we owe it to our trainees to be collaborative and to always put the patient first. This is such a fun job, and I would do it all over again. And for the folks that are listening that are rising general or vascular surgeons, there's a place for you, and we're super excited to welcome you into the field.
Yeah, in my former executive days, one of the hardest things for me sometimes was to convince people of was it's amazing when you can get done when you don't really care who gets the credit. And if you bring all the experts that you have with you to bear and just focus on what's best for the patient, and you get away from, for lack of a better word, turf battles, or frequently in my line of work, it was salary line battles. But, I get it. I don't want to take things away from people who are trying to establish a career. But if you can do the things that you guys have suggested and bring the experts to bear, and I think the trick is going to be for, now that I spent a lot of my time working in austere environments, helping them integrate, there's a lot to learn from what the military let us do about how to coordinate and how to work on a systems level. It's not a perfect system, because if so, we'd all be in it. But there's a lot to be learned from both sides. And the military learned a lot, I think, from the civilian sector in terms of how to make certain things happen. And I won't go into that in this talk, but we really appreciate everything that you and your colleagues done. This is a fantastic volume of our series that is going to be impactful for anybody who reads it. I don't care what their level of training is. There's something in there for everybody to learn from. So thank you so much.
Thank you for joining us for the Surgical Clinics podcast devoted to vascular surgery. The 4 articles discussed, as well as 9 others, are in the August 2023 issue, Volume 103, Number 4. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, Stitcher, and Amazon Music. Thanks for listening.